Hello, everyone, and welcome to today's webinar, Ask the Expert, Coding Best Practices. My name is Alex Goulding. I'm the Public Policy Manager here at iHealth and will serve as your moderator for today's presentation. Before we get started, I'd like to go over a few items so you know how to participate in today's event. Everyone on this call is listening in using your computer system by default. If you would prefer to join over the phone, just select telephone in the audio pane on the right-hand side of your screen, and the dial-in information will be displayed. You'll have the opportunity to submit questions during today's presentation by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and, time permitting, address them during the Q&A portion of today's session. Also, please note that the slides will be shared in a follow-up email after this presentation in case you want to review again or share with any peers. I would now like to introduce Renee Stamp. Renee has spent over 2 decades directing revenue cycle management and coding operations. Her areas of expertise include all aspects of revenue cycle management, coding and billing compliance, CPT and ICD training, and education. She's involved with several professional organizations, including American Academy of Professional Coders, Healthcare Billing and Management Association, and Provider Outreach and Education Advisory Group. With that, let me turn today's presentation over to you, Renee.
Good afternoon. Thank you. So in talking about the coding best practices, we'll start by looking at the definition of coding. And looking back over the past 20 years, over the continuing of coding and billing, several questions emerge. One of the things is we look at where we started. Used to, the providers would simply have a handwritten information on our SuperVille. They may circle a code, they may write things in. As we look at it over the years, it's evolved into now the codes come to the coders via an EMR. So one thing that would come to mind is, in terms of selecting your billing and coding person, what skill sets have changed in the individuals that you look for. Years ago, it was simply enough to have someone who was good with data entry. They could key in the codes. Now, there is a greater emphasis put on thought process behind that. They have to understand the guidelines. They have to understand modifier usage. There's a lot of components that they are required to look at and evaluate prior to the posting and transmitting of those codes. So it's not enough to simply have a good data entry person that can key in the data. With the EMR, one question is the provider absolved from coding responsibility? And we can discuss some of these things a little bit later. There's several questions that evolve from that. And then looking at how the physician's role has changed over the years. Used to, the physician saw the patient, and then after that, their note was sometimes handwritten, sometimes passed on to a transcriptionist. A coder picked it up, finished that, and ended up sending it on to the insurance company. Now, the physician often wears multiple hats. They're the transcriptionist with the EMR system. They're the coder because they have to assign the codes that go over to billing, and they're also a provider. So, we understand that this has led to a great frustration on their part, and it's important that their staff understands that and tries to help facilitate those different roles. So in the reimbursement cycle process, there are several components. There's the CPT code, there's the ICD-10 code, there's PQRS, meaningful use, value-based modifiers, several things that have come into play over the years. So breaking those down a little bit, let's look at the CPT code. Historically, that is what drives our providers' reimbursement. There are values that are tied to that, and depending upon if you send in the best code that meets the documentation, is the revenue that you get from that. Some of the websites that I have on the screen, the CCI edits, so the Correct Coding Initiative, that's very important to understand, and this link provides access to the CCI edits, which is maintained by CMS. There's multiple chapters 2, the CCI edits. Chapter 1 has the general guidelines. Chapter 2 deals with anesthesia. Chapter 3, the integumentary system, and etc. It goes on through the CPT book. There's a chapter for each section. Chapter 11 is dedicated to medicine and the E&M section. And it's very valuable to review this information every year. The changes are highlighted in red each year. And many important issues are clarified in these guidelines. A question that I get asked frequently is, when is it appropriate to bill an E&M with a procedure? Things like this are clarified in the CCI guidelines. Most of your carriers, especially Medicare, CMS, follows these guidelines. So it's very important to understand them and communicate them with your practice. Modifier usage. CMS and your local MAC are good resources for information such as modifier usage. For example, a couple of years ago they came out with new modifiers, XE, XP, XS, and SU versus modifier 59. And your carriers are good resources for when to apply these. I've also included some MedLearn Matter articles that are CMS articles that are very good for modifier usage. And then this link is for the Medicare Physician Fee-for-Service Payment website, also known as the MPFSDB. So I've given when you follow that link, it will take you to a website that looks like this. And you can click on the hyperlink there, the Medicare Physician Fee Schedule lookup tool, which I'll go into in just a moment and show you how that works. But then also I wanted to point out that there is a PDF file that has some very good information in it about how to use this website. So that has some very good information. At the bottom of the screen, there is a link that will take you in, and there are some very good videos that you can watch and some different training materials there. So some very good information with this. So when you go to the Medicare Physician Fee Schedule database, this is the screen that comes up, and you can select the year that you're looking for. If you're looking for pricing, you can click on the first radio button. But the second one, Payment Policy Indicators, that's what I want to focus on today. So you would click that second radio button, and then down under the Select Healthcare Common Procedure, the HCPCS criteria, you can select a single code or a list of codes or a range of codes, whichever one you're interested in. And then again, down below, if you wanted a specific locality or a specific MAC, you could choose that. And then at the very bottom of the screen, you would put your actual HCPCS code or range of codes in. And then you have to select whether you're interested in a professional component only, if it's a global service, or a technical component, you would mark that. And then it would take you to the next screen, and it would bring up this information. So I entered, just for this illustration, a 45378, a diagnostic colonoscopy. And you can see off the information that appears for this. It tells whether a modifier 26 or a TC modifier is applicable to the code. It would tell you the global days, multiple surgery. So it would tell you if modifier 51 is applicable if you had multiple surgeries performed, bilateral surgery if a modifier is required. It tells you if an assistant or a co-surgeon is allowed. So many things that are on there. It tells the type of supervision that's required. Is it direct or general supervision? And you may be wondering, all these codes, like under multiple surgery, there's a 2. And so to wonder, what does that stand for? If you'll remember on the previous screen, the PDF file that I referenced, it has those, the key for those in that document. So that is a very good tool for your coders to use and reference to determine proper modifier usage, global days, things like that. The third point under CPT was CPT code assignment. And it's very important for office managers, for the billing staff, to seek continued education, and not just to get their CEUs that they may be required for their CPC designation, but that it's quality CEUs. I also encourage coders to research any unfamiliar medical terms, pathophysiology, or procedures. They can query their providers, search out webinars, educational information from the specialty associations that their providers may be have a membership in, as well as organizations such as the AMA, AAPC, and AHIMA. Those are all good sources of information. There are also some good books such as the CDR, the Coder's Desk Reference, and that helps to translate the CPT codes into layman's terms and better understand the intent of each code. There are also books that are published at the end of every year, such as CPT changes, and so that explains the RUC committee with the AMA that develops the new codes, the intent behind that. It gives some vignettes for most of the codes so that you can see how it is designed to be used. And then another subscription is the CPT Assistant, also from the AMA. And that's very good because they highlight in each issue, you receive an issue each month, and they target specific areas. And then they also have some frequently asked questions that people have asked them, and you can have the benefit of looking through those. So those are very good sources for information. It's also important to seek out quality training at the end of the year. The ICD codes change in October, and CPT codes change in January. And so it's very important to be aware of deleted and new codes and get those updated in your practice management system immediately to avoid denials. CMS and your local MACs. CMS has national coverage determinations, NCDs. Your local MACs have LCDs, local coverage determinations, and sometimes those change, so it's very important to go out and review those. These determinations may indicate the frequency that a procedure can be performed or associated diagnoses that may be built with the CPT codes. So it's very important to search those out. All of this takes time. And most of the time the offices, it's all that they can do to the coders to stay up with posting the charges, posting the payments, calling the insurance companies on the unpaid claims. But they do need to carve out some time on a regular basis, at least once a month, to try to go out to the carriers' websites and see if there's anything that's been updated. There's frequently changes that they put out there that you need to be aware of. ICD-10 codes. So reimbursements are tied to CPT codes. So why would we care about ICD coding? Well, unless we're in the world of hospital billing with DRGs. October 1st, 2016, CMS and many carriers removed the grace period, and the specific ICD coding is now expected. Your codes that end with a 9 are generally designated as unspecified codes. And while there are times when a definitive diagnosis is not known and signs and symptoms must be used if possible, specificity should be used for code assignment. At the beginning of your ICD-10 book, there are about 32 pages with the guidelines for proper code assignment. And a lot of people, when I go out in the offices, most of them I find just picked up ICD coding as they went. They learned to look up in the front of the book alphabetically, then they might flip to the back, or they might just take the code from the front, the first code that they found. It's very important to go through these guidelines because it explains to you the way that the codes are intended to be used. So it's very important to go through that. At least go through it on an annual basis. Again, if there are any changes, they're noted up there. And it's a good refresher too. Over the years, sometimes you slip into bad habits and you forget about some of the guidelines. So it's just really good to do that. And especially keeping your providers in the habit of understanding them. And it's not as difficult as it sounds. You can pick some of the top 10 codes that you use, and during lunch, put out a little blurb on the lunchroom tables while they're in there eating, and try to go over something with them. Tape up something on the wall by where they stand out in the hall. Just something to kind of keep it in front of them to make them aware of the things that they need to document to support that specificity with ICD-10 code assignment. So some of the illustrations of why diagnosis coding is important. In the hospital setting, if you bill a 99233, which is a follow-up hospital code, and you just associate I-10 for hypertension and E11.9 for type 2 diabetes without complications, a lot of times when the carrier gets that code, that's the only picture that they have to help them understand how sick that patient is. And if you just have two codes that you could see a patient in the office for, you can see why they might deny that claim and request notes. So it's very important that your ICD-10 code selection helps paint the picture for the carrier to help them understand the acuity of the problem for the patient in that visit. So in that illustration, you can see how it helps support the medical decision making for your E&Ms. And it's not that you have, I was talking with one coder, and she said, well, there are 10 diagnoses in the chart, so that's a level 5 service. It's not necessarily the number of diagnoses, because it's supposed to be the diagnoses that are evaluated at that encounter. Now, if there's other conditions that have a bearing on your selection of treatment for that encounter, then yes, certainly you can use that code. But it definitely, you want to use the codes that pertain to that visit, and they should help illustrate to the carrier the patient's status, and that helps support your medical decision making and the medical necessity for the level of service, whether it's a level 3, 4, 5, etc. Finally, as we're moving into the world of pay for performance, how will carriers determine if the patient has good outcomes? By their diagnosis. If they have COPD, does it remain under control or is it exacerbated? They also are looking at the whole spectrum for this patient. They're looking at their hospitalizations, they're looking at their prescriptions, so the insurance carriers can tell how well the patient's conditions are being managed. They're looking, if they have diabetes, is it well controlled, or are they developing problems such as peripheral neuropathy and retinopathy? Also, some providers are part of an IPA with a capitated list, and they are paid based upon the chronic conditions of the patient. So it's important that these are accurately reported. So if I'm a relatively healthy patient on their panel, they may pay a lower rate for me than they would for someone who has 4 or 5 chronic conditions. So again, it's very important, the documentation. We've also seen over the years, as it's moving, again, the value-based payment, the pay for performance, that they are looking at the outcome of the patient. So there are other things to consider. There are some diagnosis codes, such as noncompliance. And if the patient refuses to take their medication according to what you have recommended, things like that, there are things like that that can be coded as well. So as we look where we've been, where we are, and where we're going, the bad news is that every year billing gets more complicated. The good news is that chaos always creates an opportunity for success. And especially for coders, it gives them the opportunity to play a valuable role in the success of the practice. It's like I said before, it's difficult to juggle all the responsibilities of charge payment posting, coding, working the AR, finding time to stay on top of the CPT, ICD-10, the billing guidelines. But setting that time aside, going to the carrier's websites to stay on top of the ever-changing world of healthcare reimbursement is critical. And I hope today that we've provided some additional resources and inspired you to continually seek education that will make, as a coder, the valuable asset to the revenue cycle of the practice. You know, doctors cannot keep their doors open without proper reimbursement, and the doctors don't have time to research and stay on top of the ever-changing information. And they depend upon the practice managers, upon the billing staff for the viability of their income. So that is good job security if we do our job well in this area. So that's all that I have for my presentation. I'll throw it open for questions now.
Great, thank you, Renee. We do have time to address questions, so I'll go ahead and dive in. Our first question asks, over the past several years, how has the skill set for a billing person changed?
Good question. Like I said, when they started many years ago, a lot of times people would bring a family member in or hire someone that did not necessarily have the qualifications. They just needed somebody that could key in information. And over the years, it has certainly required, you know, they have tried to move to where the states would require that offices have a certified coder. At that point, this has not been passed. There are some states like Hawaii, though, that do have that in place that require that. And so certainly the competency level of the billing staff has increased over the year, and they have to have that knowledge of CPT and ICD coding and the guidelines.
Perfect. Next question says, with an EMR, is the provider absolved from coding responsibility?
Well, ultimately, the claim goes in under the provider's name, and so they are responsible for the codes that go out. So it is very important for them to look. I know a lot of the EMRs assign these codes, and some of your practice management vendors will actually recommend that you turn that off, and so that the provider has to look at the medical necessity for the visit and if the documentation actually supports the level that they're wanting to bill. So no, they're not absolved. They are responsible for that.
All right, great, thanks. One more question here. Who is the best person to assign a CPT code? The provider, a coder?
Okay, that's another question that I hear often. A lot of people, once they have a certified coder on staff, they hire the person with the intent that they will be assigning all the codes and kind of take that responsibility off of them. The problem with that is that the physicians need to understand the documentation that's required. So, for example, the medical necessity may indicate that a 99214 is appropriate. But if the doctor doesn't understand or the provider doesn't understand that you have to have a certain level of HPI, a certain level of review of systems, a certain number of exam components in the medical decision making, and they document just a real brief paragraph, the coder is going to code what they see, which may be a 99212. So it's really important for the providers to understand what is needed for each of the coding levels. And surgeons, I see that with their operative notes. You know, it's very important to know, I always say, you know, look at the CPT code, and if a term is mentioned in the CPT book, it's important that that term is mentioned in your operative note. So it's very important that they do understand what is required for the codes, even if someone else is coding, just to make sure that they can maximize and get every cent that they're entitled to.
All right, and we do have some extra time, so actually this will be another question, and it'll be the last question we're going to ask today. What role do ICD-10 codes play in the reimbursement process for provider-based billing?
Well, they help indicate the medical necessity of the visit, and so can help support the level of service. They, such as the example that I gave in the slide presentation was the level 3 hospital visit. Those are frequently under examination by Medicare, and so you would want to be sure that it helps supports that. And then especially as we're moving forward in the pay for performance, it's very important. I know this year, in 2016, PQRS was still in effect, and there were many of the PQRS measures that were tied to specific diagnoses. And if that diagnosis was not mentioned in your note, then that could preclude you from claiming that PQRS measure. So it is very important, not only that it's documented, but documented to the highest level of specificity. So very critical.
Great. Thank you, Renee, and thank you to everyone for taking the time to attend today's webinar, Ask the Expert, Coding Best Practices. Once you leave today's webinar, you'll receive a survey on the presentation, and we would appreciate if you'd complete that and provide your feedback. As a reminder, today's slides will be shared in a follow-up email within 24 to 48 hours, and we'll also include a link to view a recording of the webinar in case you want to review again or share with any peers. On behalf of iHealth Innovations and our presenters, thank you for joining us today, and have a great rest of your day.